So today's topic is about single complete danger. So these are the contents of my topic, that is introduction, disadvantages, indication, prevalence, about maxillary complete danger and mandibular single complete danger. That is diagnosis and treatment planning, mouth preparations, impressions, jaw relations, balance, sitting, trying, insertion, recall and maintenance. Then features of combination syndrome, sequence, treatment planning and conclusion. So coming to the introductions, a single complete danger can be defined as a complete danger that occludes against some or all of the natural teeth, a fixed restoration, or a previously constructed removable partial danger or a complete danger. So single complete danger means it is a complete danger opposing natural teeth, FPD, RPD, or a CD. In a simple terms, we can understand like that. So the prime considerations is the preservation of the teeth is the prime considerations. So the major concern while planning a danger is that it is to be mostly this in most of the cases it is to be opposed by the natural teeth, at least some or maybe all of the natural teeth. So the magnitude of force which is transmitted to the danger will be more, and also due to supra eruptions of the teeth and all, arrangement of this artificial teeth also will be difficult. So we need to plan the complete danger. We need to do the diagnosis and treatment planning and the mouth preparation also properly before starting the single complete danger. So we can say the disadvantage as extensive because of this untoward unfavorable force distribution. Extensive morphological changes can happen in the danger foundation, and because of this jaw relations and extreme extreme jaw relationships, which makes it difficult to arrange the artificial teeth for the danger along the line of support. And also there is a more chance for the flappy ridges, so that the danger bearing tissue become excessively displaceable. That is, the flappy ridges are more common in the case of a single complete danger patients. So this is a exact typical example figure shows a typical example for a combination syndrome. That is, this is the most common occurrence you can common feature you can come across while planning a single complete danger. That is insufficient occlusal space due to enlarged tuberosities and altered occlusal plane and jaw relationship. So this is a maxillary single complete danger which is going to oppose the natural anteriors in the case of mandibular arch. So coming to the indications, means single complete danger is a good option when it is to oppose any one of the following conditions like natural teeth, or it can be opposed by an FPD. It also can be opposed by an RPD and also an existing CD. So our main aim while fabricating a single complete danger is preserving as many teeth as possible. So this is a single complete danger opposing the RPD and the natural teeth. So coming to the prevalence, most commonly prevalence is that maxillary single complete danger. The reason for this is mandibular canines are documented to be retained for the longest time, followed by the mandibular incisors. That is why the maxillary single complete danger is the more frequent. Opposing natural anterior lower anteriors is the most frequent occurrence. So let's see what are the steps while fabricating a single maxillary single complete danger. So first step is the diagnosis and treatment planning. So in this, we have to do the diagnosis and treatment planning for both the arches, because one arch will be completely edentulous arch and the other arch will be a dentulous arch. So edentulous arch is evaluated in a similar manner how we evaluate for a completely edentulous arch. So what are things we do for CD has to be done for the edentulous arch. And dentulous arch, we have to evaluate all the number of the teeth present and condition of the teeth present. That is, endodontic condition has to be whether it need any endodontic treatment, restorations, or the periodontal corrections. So periodontal condition has to be assessed. All this comes under diagnosis and treatment planning. And one major thing that we have to notice during the mouth preparation, one major challenge is the correcting this occlusal plane, because mostly the single complete danger will be opposed by the natural teeth. So there is chance for supra-eruptions of the teeth and occlusal plane need to be assessed, and it is corrected by the selective grinding in order to get a harmonious occlusion with the artificial teeth. So these, in which all cases we need occlusal plane correction. That is in the case of a malposed teeth, a severely tipped teeth, supra-erupted teeth, irregular occlusal plane, and less space. When there is less interocclusal space for the teeth, we need occlusal corrections. So in the figure, you can see that this is a supra-erupted premolars, which is deranging this occlusal plane. So for getting a harmonious occlusion, at the time of mouth preparation itself, we have to correct the this occlusal plane. So now after fabricating, already the occlusal plane is deranged. So in this case, they have already done, have not done any mouth preparation. So there are different methods we can use to correct the occlusal plane. And here 4 techniques are there. One is the Swenson's technique, second is the Ekstad's technique, third is the Bruce technique, and fourth is the Boucher's technique. So coming to Swenson's technique, in this we are making the diagnostic cast, that is maxillary and mandibular cast is made. And after completing this vertical jaw relation, it is then mounted at an acceptable vertical dimension with a centric relation record, and the teeth are arranged and occlusal discrepancies are corrected and marked with a pencil on the diagnostic cast. So we mark with a pencil, arbitrarily look onto the diagnostic cast, and we arbitrarily mark which all areas are supra-erupted, and using this as a guide, we need to modify the natural teeth. So in this case, in Swenson's technique, we are using the diagnostic cast and we are arbitrarily seeing it and supra-erupted or areas that need modifications are marked with a pencil, and using this diagnostic cast as a guide, we are modifying the natural teeth. In the case of Ekstad's technique, we are using a U-shaped metallic occlusal template, which is slightly convex on the lower surface, like it is shown in the figure. So in this case, you can see that this canine is under the occlusion plane, and also the first molar is also under the occlusal plane. So we have to correct the occlusal plane by giving crowns, or it is better option is to give crowns. We have to correct this occlusal plane. So this is assessed by using a U-shaped metallic template that is slightly convex on the lower surface. So we have to place that occlusal template on the occlusal surface of the remaining natural teeth, and cusps to be adjusted are identified, and stone cast modified to an acceptable occlusal relationship, and the modifications are marked with a pencil. So using this, then necessary alterations are done on the natural teeth using this as a guide. First we need to assess using this U-shaped metallic occlusal template. Then we have to modify the stone cast to the acceptable occlusal relationship, and then you have to do the necessary corrections which is marked on the cast, and using this as a guide, you can correct this occlusal plane. So coming to the Bruce technique, in this case also maxillary mandibular casts are mounted at an acceptable vertical dimension with the centric relations, and we have to do arbitrarily, we have to do necessary modifications on the stone cast. So after completing these modifications on the stone cast, we are going to fabricate an clear acrylic resin template, which is we are going to fabricate acrylic resin template on the stone cast, and then the natural teeth are modified accordingly till the template seats properly. So first we are modifying on the stone cast. Second thing, we are going to fabricate an acrylic resin template on the stone cast, and using this acrylic resin template as a guide, we are going to modify on natural teeth. And when the template seats properly inside the patient's mouth, that is fit on the cast, becomes similar to that of fit onto the natural teeth, we can stop the modifications. Likewise, using this acrylic resin template, we are modifying the occlusal plane. Correct. This is how. That is in this figure A, you can see supra-erupted molars, and we are reducing on the cast. Then we are fabricating this acrylic template on the stone cast. After that, we have to recall the patient and then try off the template in the patient's mouth. So initially it won't be fitting. After reducing these corrections, then the template will fit when it is fitting onto the cast. So that is reduction of the natural teeth using template as a guide. That is called as a Bruce technique. In Bruce technique only, we are using acrylic resin template. Next is the Boucher's technique. In this case, we are using artificial porcelain teeth are arranged on the maxillary edentulous cast in centric occlusion, establishing this occlusal plane after maxillary and mandibular cast are mounted at an acceptable vertical dimension with a centric relation record. So artificial porcelain teeth are arranged on this maxillary edentulous cast in centric occlusion and establishing this occlusal plane. So in this technique, we are using artificial porcelain teeth, which is arranged onto the articulator, and the porcelain teeth are moved over the mandibular teeth in stone, and occlusal interferences are grounded by the porcelain teeth. So we are these ground areas are marked on the cast, and the natural teeth is altered using this as a guide. So that is the Boucher's technique. So Boucher's technique, we are using artificial porcelain teeth, and we do the arrangement on this articulator, on the semi-adjustable articulator, and we will do the eccentric and centric movements. So because as porcelain teeth can wear the stone cast, it will wear the stone cast, and ground areas will be marked on the cast, and we can alter the natural teeth using this as a guide. So these are the 4 techniques that we use. That this is how we mount the in the Boucher's technique, that is occlusal plane correction using Boucher's technique. The maxillary porcelain teeth will remove the interferences of the mandibular natural teeth. So this is how we mount this artificial porcelain teeth, and this is used as a guide in the case of Boucher's technique. So these are the 4 techniques, that is which is methods to correct occlusal plane. That is, for instance, the X-stars, Bruce, and Boucher's. So, for instance, we make the diagnostic cast. X-stars U-shaped metallic occlusal template is used for the assessment. And Bruce technique, we are making an acrylic resin template. And in Boucher's technique, we are arranging this artificial porcelain teeth. So, coming to the impressions and jaw relations. Next is after arrangement, we have to, after correcting this occlusal plane, we have to go for impressions and jaw relationships. So for edentulous arch, condition of the residual ridge and philosophies of complete denture impression making dictate the method. That means how we do the jaw relation for, or how we take the impression for dentulous arch for the complete denture impression, then we have to make impression. And for dentulous arch, like we do for an RPD, we have to make impressions are to be made with an irreversible hydrocolloid following occlusal plane correction if it is required. And jaw relations are also recorded using Nis-Vonger's method, and static registration is to be used to record the centric relation. So, so we have to take the impressions and make the jaw relations. Then teeth, coming to after jaw relation, we have to go for the teeth selection. So the materials available for occlusal posterior tooth forms to oppose the natural teeth are, we have got the porcelain teeth, acrylic resin, gold occlusals, acrylic resin with amalgam stops, interpenetrating resins. So coming to the porcelains, what are the advantages with the porcelains? Actually, it has got a wear resistance, wears very slowly and maintains the vertical dimensions. And coming to the disadvantages, the fracture, wearing, and chipping of the natural teeth, because porcelain is having high wear, it has got a high abrasion resistance, so it can easily wear the natural teeth and difficult to equilibrate, and cannot be used when interocclusal distance is less, because we cannot. It is not possible to trim the porcelain teeth like we trim acrylic teeth. So it is difficult to use when the interocclusal distance is less. So coming to the acrylic resin means it is easy to equilibrate and it does not wear the opposing natural teeth because abrasion resistance is less compared to porcelain teeth. Disadvantage means in long term there will be loss of vertical dimension because of wear and tear of the teeth and a poor wear resistance. So it can cause wear and tear after many years of using. Coming to the gold occlusals, advantage means it is best to oppose the natural teeth, but disadvantage means the expense, that is, it is very expensive and also more time consuming. And next is the acrylic resin with amalgam stops. It is actually recommended by the Winkler. This is after this acrylic teeth have been balanced and occlusal preparations are in this case. Why Winkler modified this acrylic resin is that acrylic resin with amalgam stops is that he want to improve the abrasion resistance. And he want to improve the abrasion resistance of this acrylic teeth. So he incorporated this amalgam. He condensed the amalgam fillings onto the occlusal surface of the teeth. So amalgam is condensed into the preparations and eccentric movements are made. Thus, the centric holding area as well as some of the excursions are recorded in amalgam by the articulator because it has got a better wear resistance than that of the acrylic resin. So he modified this acrylic teeth to a acrylic resin with amalgam stops, like is shown in the figure. So you can see the acrylic teeth which is condensed in the centric area. Centric holding area is condensed with amalgam stops. And also next option is the interpenetrating resin. So consists of a highly cross-linked interpenetrating polymer network, and it has got also good wear resistance compared to other teeth. So these are the different types of teeth we can select for a single complete denture. And coming to the after teeth selection, we have to do the teeth arrangement. So following methods, we need to do a balanced setting, and also we have to check the achieve eccentric balance also while arranging teeth for the single complete denture. So two types of balance setting. Two methods are used to, the following methods are used to achieve the eccentric balance. One is the functional chewing technique, and second is the articulator equilibration method. So in the case of functional chewing technique is indicated in the case when the record base is having good stability and patient is having a good neuromuscular control. So this is the most accurate method of recording occlusal plateau. That means in this case, record base is having good stability and patients with good neuromuscular control. So if the patient is having poor neuromuscular control and record base is not stable, we have to go for articulator equilibration method. So following techniques are suggested, and in functional chewing technique, the first technique is the Stansbury's technique. This was the first functional chewing technique. In this case, the occlusal rim, maxillary occlusal rim, is made of the impression compound. It is trimmed buccally and lingually. We are going to trim the maxillary occlusal rim and compound maxillary occlusal rim so that occlusion is free in the lateral exertions. And we are going to add the carding wax to the trimmed area. So carding wax is to be added to the buccal and lingual area, and patient is instructed to perform eccentric chewing movements. So carding wax will get functionally molded, and the compound rim, as the occlusal rim is made up of impression compound, it will maintain the vertical dimension. And also stone is vibrated onto the wax record occlusally, and a stone record is secured to the lower member of the articulator. And denture teeth are arranged to the lower cast of the patient's teeth. And also after aesthetics is approved, we have to do the train, and stone record of the lower is secured and balance in the eccentric positions is obtained. So we need to form a compound maxillary occlusal rim, and buccal and lingual areas are to be removed, and we need to add the carding wax to the removed areas, and the patient is asked to do eccentric movements. So carding wax is functionally molded, and we have to get a stone record. That means interocclusal record is made with a dental stone, and then the artificial teeth is first arranged to the lower cast of the patient's teeth, and we have to do the train, and then we have to do the anterior train, and we have to secure the stone. Using stone record, we have to achieve the secure the lower cast, and we have to check the eccentric, both centric as well as eccentric balance we have to obtain. So balance in the eccentric position, eccentric occlusion has to be obtained, and also balancing also should be obtained. That is Stansbury's technique. Next technique is the Wiggs technique. Next functional chewing technique is the Wiggs technique. So technique is similar to that of the Stansbury's technique, except that a fin of acrylic resin is maintained at the vertical dimension instead of a compound occlusal rim. There, in Stansbury's technique, they have used a compound occlusal rim, but in the case of Wiggs technique, they have used a fin of acrylic resin. So this fin of acrylic resin will maintain the vertical dimension. And we like in the first figure, this is a fin of acrylic. This is an acrylic fin, And to the buccal and lingual sides, we are going to add the carding wax. Next is the Sharry's technique. In this case, they use softened wax rim in increased vertical dimension. So they make the occlusal rim out of wax only, but they are fabricate in the increased vertical dimension. And we are going to insert inside the patient's mouth, and eccentric chewing movements are to be made. So at that time, this wax will get abraded and generating the functional path for the lower cusp. So it is continued until we achieve the correct vertical dimension. So in this case, we are using a wax occlusal rim with an increased dimension, and patient is asked to perform eccentric chewing movements, and it is performed until the correct vertical dimension is achieved. Next is the roots technique. That is, so this technique is also similar to Stansbury's technique. That is uses, but in this case, they are using a combination of a base plate wax and a red counter wax instead of the carding wax to make eccentric registration. So the Stansbury's technique, we use the carding wax. In this case, we are using a combination of the base plate wax and red counter wax. And also we suggest the fabrication of two maxillary denture bases. That is one for recording this functionally generated path, and other maxillary base is used for the teeth arrangement. So that can decrease the number of appointments of the patients. So these are the difference. So balance setting can be performed by two methods, that is a functional chewing method and articulator equilibration method. And functional chewing method is used only when patient is having good neuromuscular control and denture base is having good stability. So we can use, in such cases, we can use Stansbury's technique, Wick's technique, Sharry's and Roots technique. But if the patient is having poor neuromuscular control and denture base is not stable, we cannot ask the patient to perform the functional chewing technique. In such cases, we have to do articulator equilibrium method to achieve the balance. So most commonly used, as it is similar to obtaining balance with a conventional complete dentures. So after mounting the cast, the teeth are arranged in centric occlusion, and it has to be decided if the lower buccal or lingual cusp is the centric holding cusp, depending upon the relationship of the upper arch. So one arch will be having already natural teeth or FPD or RPD, or combined natural and teeth and FPD. So based on the relationship to the upper arch, we have to decide which is the centric holding cusp. And we have to, after mounting the cast onto the articulator, teeth is arranged in centric occlusion. And during trying, we have to get the eccentric records are obtained, and we have to adjust the condylar settings on the articulator, and we have to achieve the eccentric balance based on the settings. And cusp are modified depending on the centric holding cusp. So that means we are not doing any functional chewing technique. We are actually using articulator, because in this case, patient is not having a good neuromuscular control, and denture base is also not stable. So for such case, for achieving eccentric balance, we have to use the articulator equilibrium method. After that, after the teeth arrangement, we have to do the trying procedure. We have to fabricate the complete denture, have to do insertion, recall, and maintenance. All these procedures are similar to that of the conventional complete dentures. So only difference is that correcting of this, there are several steps to correct this occlusal plane, and also there are several steps for achieving the balancing in the sitting. So that is the only difference we do from complete denture, conventional complete denture for a single complete denture. So thus we complete the maxillary single complete denture. So coming to the mandibular single complete denture, why we discussed maxillary means it is the most common occurrence than that of mandibular single complete denture. So what are the reasons for mandibular single complete denture? Maybe irradiation therapy or trauma. And it is actually greater challenge than maxillary single denture, because we know that already mandible is a movable member, and already it is close to the tongue. So always it is difficult to stabilize the lower denture compared to that of maxilla. And also mandible is having more amount of resorption, that 4 times more resorption than that of maxilla. And also limited availability of the good quality mucosa compared to that of maxilla. So all these things causes a greater challenge in constructing a mandibular single complete denture. So always, if the patient is willing for an implant supported prosthesis, it is the best option in the situation. But if the patient can't afford, then we have to go for a conventional single denture. But the procedures are similar for, like we described, for maxilla. And some clinicians also uses resilient liners also to prevent the soreness. So coming to the complications of a single complete denture, whether it is maxillary or mandibular, and there are certain complications we have to foresee while doing a single complete. That is a combination syndrome, wear of the natural teeth, and also fracture of the denture. So mostly, if we give a normal complete denture, that means acrylic complete denture, and opposed by the natural teeth, mostly the patients will report to the clinic within few months complaining of the fracture of the denture, because the forces which is transferring by the natural teeth to the artificial teeth will be more and can lead to the fracture of the denture. In such cases, actually, we have to plan for we can plan a single complete denture, but it should be a cast single complete denture. That means the denture base should be made up of a metal. That means cast single complete denture is the better option. The denture base should be made of a metal in such cases. So coming to the, so we will be discussing the complications. That is one important complication, which is usually as a short note, that is a combination syndrome. So combination syndrome, it is otherwise called as the anterior hyperfunction syndrome. So this is the characteristic features that occur when an edentulous maxilla is opposed by the natural mandibular anterior teeth, including loss of bone from this anterior portion of the maxillary ridge, overgrowth of tuberosities, papillary hyperplasia of the hard palate mucosa, exclusion of the lower anterior teeth, and loss of the alveolar bone and ridge height beneath the mandibular removable dental processes base, which is also called as a anterior hyperfunction syndrome, and it was described by Kelly in 1972. This is a very big definition, but when you understand the sequence, then it will be easier for you to remember. So I will be explaining how it is occurring. So if you understand the sequence, it is easy to remember all. If you by heart this definition, it is very difficult for you to remember. So I will be explaining in detail. So coming to the features, there is a loss of bone in the anterior maxilla with a subsequent replacement. So there will be, so usually combination syndrome occurs when the maxillary is completely edentulous and mandibular lower anteriors will be present. So there is loss of bone in this anterior maxilla with when there is loss of bone, it is replaced by fibrous tissues. And also because of and there will be downward growth of tuberosities and papillary hyperplasia of this hard palate and supra-eruption of the lower anterior teeth. And bone loss can occur under the lower distal extension removable prosthesis. And Saunders et al. Added 6 more additional features, that is loss of the vertical dimension, occlusal plane discrepancy, then anterior spatial positioning of the mandible, loss of stability and the refabrication of the existing dentures, Eplus fissuratum, periodontal problems of the remaining teeth. So this, if you understand, all these things are well explained in this flow chart. If you know the sequence, it is better to understand the definition of the combination syndrome. That means first the bone loss occur under the distal extension removable prosthesis. That means first the bone loss. The first thing is bone loss occur under the distal extension partial denture. Next is decreased occlusal load posteriorly and increased occlusal load anteriorly. So the resorption of bone in the anterior maxilla, because already natural teeth is present in the lower mandible. So this natural teeth will always exert more force to the maxilla. So more force will be here. And in this case, already resorption is there and decreased occlusal load. So there will be overgrowth of tuberosities. Then next is what will happen, fulcrum of rotation in the cuspid and bicuspid area. So automatically our plane of occlusion has been changed and there will be a fulcrum of rotation in the cuspid and also bicuspid area. So that is a change of occlusal plane is happening. So that will causes a negative pressure in the posterior palatal seal area. So there will be fibrous growth of tuberosity and also papillary hyperplasia of the palate. So because of this negative pressure, because already there is a fulcrum of rotation in the bicuspid area, and also there is change of occlusal plane. So the overgrowth of tuberosity, because of the negative pressure in the posterior palatal seal area, there is overgrowth of tuberosity in the posterior aspect, and also the resorption resorption of the bone in the anterior maxilla, which is replaced by the fibrous tissue. So that can cause loss of stability of the denture, and resorption in the anterior maxilla causes labial flange to irritate the labial mucosa. When there is resorption in the anterior maxilla, that will irritate the labial mucosa and also produces Epulis fissuratum. And lower anteriors will supra-erupt, and poor oral hygiene contributes to the periodontal problem. So because of this resorption in this anterior maxilla, this lower anteriors will supra-erupts, and it can cause periodontal problem. So if you understand this sequence, it is better to understand. So now if we see the definition, you can easily understand. That means definition means the characteristic feature that occurs when an edentulous maxilla is opposed by the natural mandibular anterior teeth. This is the common condition in which combination syndrome occurs. That is, maxilla will be completely edentulous, and anterior mandibular teeth will be present in the mandibular arch. So that includes loss of bone from the anterior portion of the maxillary ridge. That is the loss of bone from the anterior portion of maxillary ridge. Then overgrowth of tuberosities. Then papillary hyperplasia of the hard palate, and that can cause extrusion of the lower anterior teeth. So loss of alveolar bone and ridge height beneath the mandibular removable dental processes base. We call it as anterior hyperfunction syndrome. So if you, first of all, you have to know how the sequence. So you have to compare this flow chart and this diagram. Then you can easily understand the definition. Then go back to definition again and study the definition. So coming to the treatment planning, systemic factors like diabetes and osteoporosis that increase the rate of resorption of the bone. Dental factors, for example, in the case of class 3 jaw relationship, there will be increased pressure in the anterior maxilla. And when the lower anteriors are retained for a longer time, patient is accustomed to bite in the anterior region. And also, if the patient is having any parafunctional habits, also that increases the bone resorption. And type of the occlusal scheme also has direct effect on this development of the syndrome. So coming to the rationale, so prevention, we have to reduce the maximum amount of ridge resorption. So for preventing the rapid resorption of the bone under this lower RPD, always we have to take a proper impression, and extension of the RPD up to the retromolar pad is very much essential, because it can increase the stability. And also prevention of the excessive load in the anterior region by providing the stable occlusal scheme. That is why we need to correct the occlusal before starting the treatment for a simple complete denture. We have to correct the occlusal plane, and only then a stable occlusal scheme can avoid this combination syndrome. Not avoid, reduce the effects of combination syndrome. And posterior occlusion free of interfering contacts during centric and eccentric movements also can reduce the combination syndrome. And minimum contact in the anterior region even in protrusive movement, because when the anterior mandibular teeth contact the maxilla, there will be more resorption in the anterior maxilla. So if you plan a minimum contact, that also can reduce the amount of resorption. And anterior teeth to be used only for the phonetics and aesthetics. So when you arrange the artificial teeth, try to avoid contact in the protrusive movements as well as in centric movements. So it is kept only for the purpose of phonetics and aesthetics. And also we have to educate the patients. Always we have to, prevention is always better than cure. So try to avoid the situation in which you can arise the combination syndrome. So always educate the patient to motivate for better treatment options, because when a situation comes, we cannot avoid the combination syndrome. So coming to the prevention, retaining the weaker, so always prevention is better than cure, but try to prevent the situation. That is only when the maxilla is completely edentulous and mandible with lower anteriors present, this combination syndrome arises. So try to remove that, try to prevent the situations. That means first of all, when a patient comes, you can ask the patient you can ask the patient and educate the patient and try to retain the weaker posterior teeth by doing RCTs and periodontal techniques. Don't send the patient for extraction of the teeth. Then also we can fabricate the fixed prosthesis in lower posterior region using, if the patient is affordable for implant options, you can also fabricate a implant supported dentures. Then plan for tooth supported over dentures in the lower arch, and also we can recall the patients frequently to check for the resorption, especially in the case of lower distal extension prosthesis. So coming to the conclusion. So single complete denture opposing natural or resorbed arches is a greater challenge than that of conventional complete denture for the clinician, because this is mainly due to the difference in the support mechanism of the natural and artificial teeth. So the problem must be recognized and appropriate treatment should be provided to ensure a stable and comfortable prosthesis which will preserve the supporting tissues. And patients should be educated regarding the uniqueness of this treatment modality. That means if you are giving a complete denture, if you are giving a maxillary complete denture and mandibular distal extension RPD, you have to inform the patient that there is a situation called combination syndrome which can arise in future. So the patient will be and also before extraction, you can educate the patient like if we extract, it can lead to, even after fabrication of FPD or even after the fabrication of the single complete denture, there a situation can come like combination syndrome. So we have to motivate the patient. So our main aim is motivate the patient to prevent this combination syndrome situations. That means, and also if you are planning for a complete denture, do a proper occlusal correction and try to do a balanced sitting. So that is very important when you give a complete denture. Make it as comfortable as for that particular patient. So these are the that's about the single complete denture.